The topic is open for discussion. Any questions, concerns, please address to the panelists, please.
Sorry, could you offer any insights as to why the vast majority of cardiac surgeons are delivering what you described as suboptimal revascularization by the use of only single arterial grafts and also suboptimal medical therapy, which I think you described as unethical?
Thank you for that interesting question. To answer them in the reverse order, I mean, it's astonishing when you look at the Syntax trial that even patients who had undergone PCI with drug-eluting stents, only 50% of those were on optimal medical therapy and only 25% of CABG patients. And it is simply unethical to be doing interventions on patients that may affect them for the rest of their life and not to ensure they're on optimal medical therapy. I mean, it's simply indefensible. With regards to why are there so few arterial grafts being used, I don't quite understand it. We showed in the ART trial that using a second mammary artery adds 23 minutes to what is essentially a 3.5-hour operation. And I don't understand it because if a surgeon can use one mammary artery, so in contemporary practice, 97% of patients get a single mammary artery. So there's very high use of it. So if a surgeon can use the left mammary artery, there's absolutely no reason why they can't use the right mammary artery. So I just don't get it.
What is the role of the radial artery as the second arterial graft rather than the mammary artery?
Okay, so good question. So I've got a very nice lecture on this, I won't give it, but let me just sum it up by saying, if you look at the angiographic patency of both mammary arteries, they're over 90% at 20 years of follow-up. So there is no current evidence that the radial artery is like that. But where there is definite evidence is that the radial artery is far superior to vein graft in terms of patency at 5 years, as long as it's been used to a vessel with greater than a 70% stenosis. So radial artery is definitely better than vein, and it may be preferable in obese diabetics where you don't want to use two mammary arteries. But at this stage, it doesn't have the same weight of evidence over the long term as a second mammary artery.
Just a comment on the suboptimal medical therapy. I think one of the problems, I mean, I work in a cardiac rehab program, is the kind of the powerful words of the interventionalist or the surgeon saying we have fixed everything. And so many people come and tell, oh, I was told everything is fixed. Why are you trying to give me all these medications? So it's very, very important that when you do intervention that you tell the patient that this has temporized an issue, that the underlying cause remains completely untreated. And I think that makes it easier for people to accept medications. And also I think when you go for interventions too early, many are not on optimum therapy. And when they come back later, it becomes much more difficult to put them. I mean, we know patients with coronary disease, people who have had a heart attack, nobody questions when they give them 4 or 5 medications at the time of the MI, but if you try to add one more once they come back, it's a lot more difficult because people say, I'm doing well, why are you adding this thing?